Behind New Jersey's cul-de-sac, silence, another sound is growing. The click of a pharmacy drawer snapping shut on empty space. Thousands of seniors now live in the gap between a bottle and its price, working jobs by day and counting tablets by night. One denial, one formulary sweep, and everything that keeps them alive disappears before sunrise. There was a horrific crash of an ambulance outside Newark, Beth Israel on the interstate, and the crisis is drawing people from every retirement zip code. This is not a coverage gap. It is survival inside a formulary that is collapsing in plain sight. And if this can happen in the nation's densest corridor of Medicare voters, how long before it reaches your kitchen counter? Let's get something straight right now. Losing Medicare. Part D is not the same as losing a coupon. A coupon costs you $10. Losing Part D costs you your kidneys. Part D is a 76-year-old former postal worker choosing between a 30-day supply of Eliquis and the electric bill. It is keeping your insulin cold in a neighbor's fridge because you cannot open yours. It is driving to 3 different CVS stores before your shift starts, praying one computer still says covered. New Jersey does not track termination the way Florida does. There is no public count, no designated emergency refill protocol, no recognition in the state's uninsured statistics. But walk through the pharmacy lines of Cherry Hill, the strip mall counters in Toms River, or the Walgreens at the edge of Morristown after 9 p.m., and you will see them, dozens of retirees clutching brown paper bags and denial printouts. These are the medicinally homeless that data misses. People who do not fit the visual narrative of crisis we are used to seeing. They are not on stretchers, they are on line 12, and the systems designed to keep seniors healthy were never built for them. Domino 1, the rent death spiral, Pharma Edition. Here is how it starts. The median Part D premium in New Jersey hit $52 a month in 2025. That is $624 a year, more than the annual food budget for half the seniors on fixed incomes. To afford that without being benefit burdened, you need to delay retirement until 73. The state's actual median retirement age is 64. Do the math. A single Eliquis prescription lists at $678 a month. A Social Security check averages $1,710. Take away rent, utilities, gas, and the math does not merely fail, it hunts you. Every January, the gap widens because insurers reshuffle formularies while COLA, the cost of living adjustment, crawls at 3.2%. Every January, more people slip through. Dolores worked 31 years as a school lunch aide and never missed a premium. Then her plan got bought by a private equity insurer. Her insulin tier vanished overnight. Her copay jumped from $47 to $495. She asked for an exception. They said the drug was still covered, just not for her dose. She tried GoodRx. The coupon worked once, then expired. She bought a 30-day supply on a credit card, moved the balance, and started cutting 10-unit injections down to 6. That was 18 months ago. She is still cutting, still working part-time at the parish raffle, still one refill away from diabetic coma. Domino 2, the 72-hour shell game. Federal rules give plans 72 hours to mail a termination letter after the cut is logged. Pharmacies receive the revoke signal instantly. Seniors learn while standing at pickup, but move where? Another chain, same PBM backbone. Another town, same formulary. The 72-hour rule means you must find a covered drug or pay cash within 3 days or go without. Without is not an option when your heart is held together by a thin white pill. Dolores drives to 3 CVS stores, 2 independents, 1 Costco. All show the same red block, patient not covered. She calls the plan, holds for 94 minutes, gets disconnected. She calls again, holds for 76 minutes. The representative says the letter is in the mail. She checks her mailbox. Nothing. Meanwhile, the bottle on her counter empties a quarter turn each night. She considers the emergency room, remembers the $250 copay, and stays home. On the 4th day, she wakes with a chest flutter and a tongue that feels like wool. She takes a half pill, splits the remaining powder with her finger, swallows, and waits for the room to stop shimmering. The enforcement is not random, it is systematic. A computer flags a high-cost claim, an algorithm mails a denial, a patient stops breathing. You cannot park in the same spot for more than 72 hours without moving. You cannot live in the same body for more than 72 hours without medicine. The law does not stay neutral. It activates the shell game with nowhere left to migrate. Domino 3, infrastructure collapse creates medical emergencies. Living without coverage means no legal access to refills, no stable price, no predictable pharmacy. People shower at gym sinks to stay awake for the next store opening. They charge phones in library corners and hope the Wi-Fi holds long enough to reload the formulary page. They use fast food bathrooms to cry where no one notices. Waste disposal becomes dangerous improvisation. Half tablets split on dashboards, powder blown into cup holders. In summer, pills melt on dashboards. In winter, they crack like ice. Robert is 71, a retired trucker managing atrial fibrillation while living in a 2003 Accord. He keeps his Xarelto in a glove box cooler, but a heat wave fried the seal. The bottle now smells like vinegar. His copay would be $430. His checking balance is $41. He takes one pill every other day, a choice between blood clot or bank overdraft. Last month, he woke with half his face drooping. The ambulance ride cost $1,900. The emergency room doctor told him he needs stable dosing. The social worker told him the shelter has no secure medication storage. He chose the car over the shelter because the car still has a lock. The health impacts multiply. Sleep deprivation from driving pharmacy to pharmacy, hypertension from constant price shocks, depression from scrolling coupons at 3 a.m., mental health crises from chronic stress and social isolation. And when winter hits, people die. Every year, seniors have strokes in New Jersey parking lots because they could not afford the 30-day bridge supply. Every year, the state tallies the bodies as natural causes and moves on. Domino 4, displacement without destination. When New Jersey cracks down on high-cost drugs in one plan, patients do not disappear into cheaper coverage. They migrate to the next formulary. Trenton denial pushes them to Camden. Camden rejection pushes them to Cherry Hill. Cherry Hill refusal pushes them to Pennsylvania, where they are even farther from their primary doctors, their grandchildren, their last known pharmacy. This displacement paradox means enforcement costs more while making everything worse. Towing a patient off a drug costs the system a $1,000 emergency room visit within 6 weeks. Meanwhile, the senior loses their stability, their dignity, and frequently their independence because they cannot get to the grocery store anymore. The result is a crisis that gets more expensive and dangerous with every intervention that does not provide affordable coverage. More ambulance rides, more strokes, more people cycling through rehab facilities because they could not pay for pills, and absolutely zero reduction in the actual number of people experiencing medical homelessness. You cannot surcharge or coupon your way out of a coverage crisis, but that is exactly what New Jersey keeps trying to do. A system that deletes your medicine overnight leaves you with one final calculation: risk versus breadth. Well-lit chain pharmacies offer predictable prices, but the denial arrives faster. Independent corner pharmacies offer charity, but stock runs out by Tuesday. Hospital discharge counters give you 7 sample pills and a prayer card. Residential mailboxes have 0 refills left. Industrial zone parking lots let you cry in private, but the security guard taps the glass at 2 a.m. There is no safe choice, only degrees of danger. Margaret is 78. She taught second grade for 34 years, paid every tax on time now. She lives in a 2004 Corolla because her pension of $2,000 a month cannot cover rent and the $1,089 list price of her cancer pill. She parks in different lots every night to avoid the shame of neighbors seeing her sob. But the constant movement is destroying her kidneys. She needs scheduled hydration. She needs labs every 3 weeks. Without an address, she cannot receive the appointment postcards. She missed 2 oncology visits. The tumor marker doubled. The oncologist told her stable housing would improve survival by 38%. The shelter told her she would have to surrender the car, which contains her late husband's photo, her teaching awards, and the last thing she controls in her life. She chooses slow decline over the loss of the only roof she has left. David is 69. He has a master's degree and works part-time at the library, making $17 an hour. That should cover generics, but his student loan garnishment is $200 a month. After taxes, he brings home $1,400. The cheapest Part D plan is $139. That leaves him $1,261 for rent, food, utilities, gas, and the $840 price of his Parkinson's tablets. He lasted 4 months before his savings evaporated. Now he sleeps in a 2013 Prius and showers at the Y. He has not told his boss. He is terrified they will cut his hours if they find out. But he is so exhausted from sleeping upright that his hands shake worse than the disease. He dropped a stack of returned books last week. The supervisor asked if everything was okay at home. He said yes, because admitting he does not have a home means admitting the math was impossible from the start. And then there is Carmen. She found a bridge program, not in New Jersey. She took a bus to Connecticut because they actually have one. Within 48 hours of arrival, she had emergency coverage, a caseworker, and a temporary supply. Within 30 days, the caseworker helped her file an exception that restored her full benefit. Within 90 days, her copay dropped to $9, and she was sleeping through the night. The program cost the state $42 per enrollee. A single emergency room visit cost $2,300. The difference? Connecticut treated her termination as a systems error that needed fixing. New Jersey treats her as a budget line that needed cutting. Blueprint 1, the Bridgeback Pharma Edition. 3 models have proven effective in halting termination spirals with measurable outcomes. States like Connecticut, Vermont, and Washington run emergency Medicare Part D bridge programs that provide immediate temporary coverage and assign a caseworker within 72 hours. The results are staggering. 92% of participants regain stable coverage within 4 months. Program costs average $38 per person versus $1,137 for an ambulance plus emergency room admission. The model works because of 3 key elements. First, instant override. Pharmacists can activate a 30-day emergency fill with 1 phone call, no week-long prior authorization, no complex eligibility maze. If your plan cuts you off, you are in. Second, co-located services. Case managers, state pharmacists, and Medicare counselors staff a hotline that operates nights and weekends. Participants do not have to navigate 5 agencies across 2 states. Everything they need is 1 callback away. Third, restoration integration. Staff file exceptions, select new plans, and transition members to permanent coverage. The bridge is not the solution. It is the stable platform that makes the solution possible. Vermont operates a universal formulary rule that forces every Medicare Part D plan to cover 150% of the Centers for Medicare and Medicaid Services benchmark drugs. Terminations for cost reasons are outlawed. Denial rates dropped 67% in the first year. Premiums rose 1.8%, less than the national average. The policy costs the state $0. It simply writes the rules insurers must play by. Allegheny County, Pennsylvania, runs a script triage center that processes 200 termination calls daily. The program offers immediate services like 90-day emergency supplies, copay assistance, and mail order rescue packs, plus longer-term support through housing and nutrition referrals. 78% of callers successfully regain coverage within 60 days. The center costs $1.2 million annually, but prevents an estimated $6.8 million in hospitalizations. That is a 5-to-1 return in the first year alone. The strongest programs share key performance indicators: emergency fill within 24 hours, case manager callback within 30 minutes, appeal filed within 7 days, permanent plan placement within 45 days, retention above 85% at 12 months. Programs hitting these metrics achieve 80% transition to stable coverage within 1 year. But programs alone are not enough. Policy has to change. First, scrap the 72-hour notice loophole, require plans to authorize a 30-day emergency, fill the moment a termination posts. Second, create an automatic bridge enrollment into state Medicaid WRAP for any senior denied coverage. Add the infrastructure, a fax from pharmacy to state, paid back by the federal government at 100%. Third, upgrade oversight. Fine plans, $5,000 per wrongful termination, real money instead of parking tickets. Fourth, include formulary stability in federal reviews. Right now, the Centers for Medicare and Medicaid Services scores plans on phone wait times, but not on how many drugs vanish mid-year. Advocates need to push for stability metrics that unlock star rating penalties. The bridge back starts with a single law that says no senior leaves the pharmacy empty-handed. Blueprint 2. The math is clear. Over 64,000 New Jersey seniors were terminated in 2025, and thousands more are rationing pills the system refuses to count. They are not choosing this. They are surviving an equation that no longer adds up. Premiums are rising faster than the cost of living adjustment, formularies are shrinking faster than form letters, and pharmacy laws feel like punishment. But solutions exist. Emergency bridge programs, universal formulary rules, and real-time override protocols have already proven effective in Connecticut, Vermont, and Pennsylvania. They cost less than ambulance rides, work faster than appeals, and actually move people back to stable coverage. New Jersey could start a pilot program in 60 days, pass one emergency statute, fund 5 pharmacy override hotlines, and partner with existing state universities for case management. The funding exists, the infrastructure exists, the seniors exist. What is missing is political will and public pressure to demand it. Dolores returns to the same counter 41 days later with a new plan card in a shaking hand. The pharmacist scans it. The copay is still $495, and they moved insulin to the specialty tier. She pockets the card and walks out into the sunrise, pills left on the counter like unclaimed lottery tickets. The bridge back starts the moment we decide no one should park their body in a parking lot just to stay alive.